Total bilirubin measures both indirect and direct bilirubin. Direct would be considered conjugated and indirect unconjugated. Elevations in total bilirubin could be due to an increased unconjugated bilirubin, conjugated bilirubin, or both. It's mainly used to evaluate liver function. It also can be used for hemolytic anemia, neonatal jaundice, and when we are looking at bilirubin testing, we could consider doing a hepatic panel that includes total and direct bilirubin, and then you can calculate indirect from those. If you order this just through a comprehensive metabolic panel, you'll get total bilirubin only. And if that's elevated, you need to request a direct bilirubin to calculate the fractions. A reminder of bilirubin metabolism. Senescent RBCs, red blood cells, are sequestered in the spleen. Hemoglobin then, or heme actually, excuse me, heme is released from hemoglobin and converted to biliverdin, which then is converted into unconjugated bilirubin, which binds to albumin to get transported to the liver. From there, glucuronic acid is added to bilirubin. So we have that UDP gluconeryl transferase enzyme, and that's when we get conjugated bilirubin in our liver, and that's secreted as into bile. That bile is secreted from the gallbladder, where it's stored, to the intestines, and the majority of it's eliminated in feces. A small amount of it is eliminated in the urine. So we have some values here. Critical values for neonates and adults are listed as 12 or 15, greater than. Some factors that interfere with bilirubin include hemolysis or lipemia, because the spectrophotometric test as light will destroy or convert bilirubin. Air bubbles or shaking your specimen can destroy bilirubin, which is why it's really important to gently invert, not to shake the specimen. And prolonged fasting or anorexia can increase values as well as drugs. So if we look at increased indirect or unconjugated bilirubin, which is a calculation we can do, some pre-liver, pre-hepatic causes involve hemolytic anemia, transfusion reactions, heart disease, and hepatic causes involve hepatitis, cirrhosis, Gilbert's disease, or even neonatal jaundice. Increased direct conjugation or conjugated bilirubin, we have either intrahepatic obstructions or post-hepatic obstructions. So inside the liver, there's lots of things that can cause obstructions themselves, from cancer to inflammatory conditions to even medications like OCPs. So lots of potential options there. Post-hepatic obstructions, we think of really gallstones as being the primary factor, although pancreatitis could also be a secondary. And then there are some congenital intrahepatic causes such as Dubin-Johnson or Rotor syndrome. In neonates, the most common reason that neonates need medical attention is due to increased bilirubin. Physiologic jaundice is a normal phenomenon during kind of this transition, but it becomes concerning when levels continue to rise. Unconjugated bilirubin is neurotoxic, so this could potentially damage the neurofunctioning of an infant. Physiologic jaundice is a normal, well, not normal, but it's a progressive rise in total bilirubin between 48 and 120 hours of life. It peaks between 3 to 4 days or 72 to 96 hours. It's due to a higher postnatal load of bilirubin and a lower amount of liver conjugating enzyme activity or UGT activity. And in every newborn, it occurs to some degree. We can see in hyperbilirubinemia clinical outcomes, we would often see skin and mucous membrane deposition of bilirubin, which looks like jaundice, the yellowing of the skin and the eyes. Unconjugated bilirubin can deposit in the brain and lead to acute bilirubin encephalopathy, and that could lead to permanent neuronal damage, which is what we're trying to avoid. Now, jaundice or icterus, newborn icterus, is notable once total bilirubin is greater than 5 to 6 versus older children or adults once it's greater than 2. This will progress cranially to caudally, and our visual assessment is subjective. It is often inaccurate and it's dependent on experience. So it's really important to get familiar with what jaundice looks like in a variety of different skin tones and skin types and skin colors, so you can become more susceptible at identifying these cases. There are 5-point scales that can rate the cephalocaudal extent of jaundice, but it's a weak correlation between predicted and actual levels. Looking at kind of our differential diagnosis of indirect hyperbilirubinemia, try to say that 3 times fast, we can see there's disorders of production, so increased red blood cell destruction, and we have a lot listed here. We would consider looking at additional studies to obtain blood typing and Rh screening of mother and infant, a DAT-Coombs testing in infant, a CBC looking at reticulocyte count and a blood smear to look for hemolysis. And we'd also want to look at liver values, such as our albumin levels, LFTs, TFTs. We may consider a liver gallbladder ultrasound or even a HIDA scan to rule out biliary atresia. Now that we've looked at bilirubin and some of their testing and some of the ways that we can calculate indirect bilirubin, we're going to transition over to liver function testing.